here with us today. I see a lot of friends on this call, so I'm super excited that you all joined us on this snowy day. I guess that's the benefit of COVID, is that we don't have to worry about canceling of the snow. Nothing changes. Everything's exactly the same. As my kids were very disappointed that there's not going to be a snow day. So I'm Elena Ratner. I'm one of the GYN oncologists, and Gloria Huang is with us, who is one of my colleagues, an associate professor of GYN oncology at Yale University. And we provide care all through the state of Connecticut, all the way from New Haven to Greenwich. And Dr. Huang actually now provides care in Greenwich full time, which we're super, super excited about. And Dr. Daniela Addeo, who's with us, who is an amazing radiation oncologist in the Greenwich community. And we're so excited that you're here with us today to talk about gynecologic cancers and what has changed in the management of these cancers. And this is very informal. So as you ladies have questions that you would like to ask, please put them in the chat and I will be watching the chat and we can talk about them as we go. Otherwise, we'll start. Dr. Huang, if you would like to start talking a little bit about early detection and the advances that we've made, and then I will add to your presentation. And then Dr. Addeo, if that's okay, we will.
I have actually, because radiation, it's a little bit, probably not, people don't know so much about, so I have like a PowerPoint with some slides.
Okay, wonderful. That's great. So we'll proceed like as that. So Dr. Huang?
Wonderful. Thank you so much for the introduction, Dr. Ratner, and hello to all of our guests, and thank you so much for joining us today. I actually made some PowerPoint pictures as well, so I will try to share those and get started now. So let me just go ahead and do my screen share. So I'm happy to talk about recent advances in gynecological cancer prevention, early detection, and treatment today. To review what I'm talking about, gynecological cancers, these are cancers that arise from the female reproductive system, with the most common being uterine cancer arising from the womb, most often the lining of the uterus called the endometrium. Ovarian cancer, which actually encompasses ovarian, fallopian, and peritoneal cancer, and then cervical cancer, which arises from the neck or opening of the womb. These are the three most common types of GYN cancer. Let's see if I can advance here. Just how common are these cancers? Uterine cancer is the most common, and about 1 in 35 women in the US will receive this diagnosis during their lifetime. Ovarian cancer is the second most common, with about 1 in 70 women developing ovarian cancer. And cervical cancer is less common now due to improvements in prevention and detection, with about 1 in 160 women developing cervical cancer. Cervical cancer is a great example of how far we have advanced in prevention and early detection. So we are able to prevent the vast majority of cervical cancers through HPV vaccination. And in addition, we have modalities of early detection using cytology, most commonly known as Pap tests, and HPV testing. So the vast majority of cervical cancers are caused by HPV, human papillomavirus infection, with HPV infection rates historically have been most adults, about 85% or more of adults having been infected by HPV. And usually our immune system clears the infection and no further sequelae developed. However, in some women and men, persistent HPV infection can develop, which actually can lead to the virus genes becoming part of the cell's DNA, called integration. And that is the type of HPV infection that can lead to precancer and cancer lesions. As I said, we are lucky enough to have cancer prevention for cervical cancer, and that consists of the HPV vaccine, which in this country is the Gardasil 9. Not only does this prevent over 90% of cervical cancer, but 5 additional cancers are related to HPV infection, and these include oropharyngeal, which is throat cancer, anal cancer, vulva, penis, and vagina cancer. So these vaccines work the best when they're given at an early age. Usually around age 11 or 12 is the ideal time. And in younger patients, only 2 shots are needed. In older teens and adults, 3 shots are needed to have a good preventive effect. Screening has evolved over the years, and screening is still done for women who have and have not received the vaccines. However, in order to kind of reduce the invasiveness of screening and reduce tests and invasive procedures, we now start screening at an older age, so 21 and up. And also, we have longer screening intervals for low-risk patients. So while previously patients were going every year for a PAP, now we still recommend wellness visits. However, the actual PAP and HPV tests can be spaced at an interval of 3 to 5 years. And then also discontinuing screening in patients at very, very low risk, such as those who've had a hysterectomy with removal of the cervix, not related to precancer, or elderly women who've had many negative PAPs and no history of precancers. Just a caveat that these are general guidelines for low-risk patients and don't apply to high-risk patients. So high-risk patients are patients who might have immunosuppression or who've had a history of persistent HPV infection or precancer. In terms of future directions, an alternative has evolved, which is primary HPV screening with typing of the HPV, and we'll see this more and more with HPV screening, typing, and then determining what, if anything, needs to be done further. I am so proud to say that Connecticut is a national leader in HPV vaccination. So while the United States as a whole has lagged vaccination rates compared to other developed countries, actually Connecticut, over 50% of eligible women have been vaccinated, and this is directly related to about a 50% decrease in cervical cancer deaths since the introduction of HPV vaccines in 2006. So it really is a success story. Now we still see about 12,000 patients per year in the US who develop cervical cancer. And we have, in terms of recent treatment advances, we can now offer individualized surgical treatment. So when cervical cancer does develop, it's often in women in their 30s and 40s, for some of whom fertility sparing to have a family is important. So we do have the ability to offer fertility sparing surgery to preserve the uterus and allow women to have families. In selected patients. In addition, another big advance for patients who have recurrent or metastatic cancer is being able to offer patients immunotherapy when appropriate, which really has improved outcomes as well. In contrast to cervical cancer, where we have declining rates, endometrial cancer rates are actually increasing. So there's year-over-year increases in the number of cases and deaths from endometrial cancer every year. And this is partly related to the obesity epidemic. Over 90% of endometrial cancer is obesity related, so in part related to obesity and related conditions such as diabetes and increased insulin levels. About 5% are genetically related, such as Lynch syndrome. And then there can be other factors such as unopposed estrogen or tamoxifen. So we have good ways to lower endometrial cancer risk. And these include maintaining a healthy weight, exercising 5 or more days a year. And we know that taking oral contraceptives or using a Mirena, a progesterone IUD, can be helpful for reducing long-term risks long-term. Avoiding unopposed estrogen if you have a uterus, and really to be aware of what are warning signs. So any bleeding or spotting after menopause is abnormal and should prompt a gynecological evaluation. And we know how Lynch syndrome can impact cancer risk, including risk of colon cancer, endometrial cancer, and ovarian cancer. So women who have Lynch syndrome should be followed with enhanced screening. Cancer screening for endometrial cancer can include exams, ultrasounds, and endometrial biopsies. And then we can offer women with Lynch syndrome risk-reducing surgery, usually consisting of hysterectomy and removal of the tubes and ovaries after childbearing is completed. I also wanted to highlight recent advances in the surgical treatment of endometrial cancer. So over the past decades, we have really moved to the point where almost all of our endometrial cancer patients are being treated in minimally invasive surgical approaches, laparoscopic and/or robotic assisted. And this offers short recovery times and quick resumption to usual activities, and really decreases the morbidity of an endometrial cancer diagnosis. And in fact, often less is more, and this is illustrated by selective lymph node evaluation with procedures such as sentinel node evaluation, which can be very sensitive for detecting disease outside the uterus while decreasing potential side effects. I also wanted to highlight that endometrial cancer, we really have moved into the era of precision medicine. So we currently perform molecular testing on all endometrial cancers to detect protein changes in the tumor cells that can indicate a potential presence of Lynch syndrome, and also these protein changes called immunohistochemistry can guide our treatment decisions as well. In addition, immunotherapy is available for most patients with recurrent or advanced endometrial cancer. And in fact, we have a number of clinical trials ongoing now, also looking at immunotherapy in the frontline setting for patients with higher risk endometrial cancer. We also are actively investigating how we can best deploy endocrine therapies, hormone therapies for endometrial cancer, which, as you know, are very much the mainstay of breast cancer and prostate cancer treatment, and are under active investigation. In fact, I'm leading one such national trial right now, which hopefully will lead to some new ways to treat endometrial cancer. And more you'll see that we'll be incorporating targeted therapies in the frontline and recurrent setting. In terms of endometrial cancer survivorship, this is such an important part of endometrial cancer care, because we have excellent oncological outcomes in endometrial cancer, very high cure rates, especially in patients with early stage disease. And in fact, long-term follow-up shows that most endometrial cancer patients are more likely to die of heart disease and other chronic conditions rather than from endometrial cancer. And this highlights how important it is to incorporate lifestyle changes as well as part of endometrial cancer survivorship. Moving on to ovarian cancer, our understanding of ovarian cancer has really greatly advanced over the past decade. And how we conceptualize ovarian cancer now is based on the origins of ovarian cancer, with type 1 actually often arising in endometriosis, which is a very common benign condition of reproductive age women, as well as from borderline precursor lesions. In contrast, type 2, which are the tend to be more aggressive, it often actually arises in the fallopian tube lining cells initiated by in situ cancer cells called STICs. So this is really kind of a paradigm shift in how we understand ovarian cancer, and is related to understanding more of the molecular and genetics of ovarian cancer. We know that there's several very well established ways that we can lower our ovarian cancer risk. Breastfeeding and pregnancy are associated with decreased ovarian cancer risk, and really anything that decreases the number of lifetime ovulatory cycles, including oral contraceptive use during the reproductive years. In addition, removal of the fallopian tubes, such as having salpingectomies for tubal ligation, can greatly reduce the risk of ovarian cancer. Women, especially if they have first-degree relatives with breast cancer or first-degree relatives with ovarian cancer or personal history of breast cancer, should consider genetic counseling and high-risk screening. Just wanted to highlight some of the warning symptoms and signs of ovarian cancer, which unfortunately can sometimes be vague, such as abdominal bloating, increased waistline, pelvic pain, change in bowel bladder habits, abnormal bleeding, nausea, or feeling of fullness. And most of concern would be when these symptoms are persistent and don't go away on their own, and that should prompt a gynecologic examination. We also have learned a lot about hereditary breast and ovarian cancer syndrome, which are, you've probably all heard of BRCA1 and BRCA2 mutations. So we have very good ways to detect the presence of inherited changes through blood or saliva tests. And that is to detect whether you've inherited one of these genetic changes from your mother or father. Women with hereditary breast and ovarian cancer syndrome benefit from high-risk screening, risk-reducing surgery, and I just wanted to highlight that the risk-reducing surgery is done in a minimally invasive ambulatory surgery, usually takes less than 1 hour with tiny incisions, and is recommended around the ages of 35 to 45 after completion of childbearing. Of course, this is individualized based on the patient and the patient's individual considerations. And lastly, I would like to highlight some recent advances in ovarian cancer treatment. We know more and more that tumor debulking remains a cornerstone of optimal treatment and improved survival. Seeing a gynecologic oncologist and having surgery either at the initial diagnosis or at an interval after chemotherapy is important for optimal chances of survival. We recommend genetic counseling and testing in all women diagnosed with ovarian cancer. In addition, for all women with advanced ovarian cancer, we suggest tumor molecular testing, and this is important because it really guides treatment decisions on how can we most effectively treat the women's cancer. So I'd like to summarize with some take-home messages about each of the major types of GYN cancer. The great news is that cervical cancer is preventable through vaccination and screening. For endometrial and ovarian cancer, surgery by a gynecologic oncologist remains a cornerstone of treatment and maximizes survival. And we can now offer precision personalized medicine for all patients with advanced gynecological cancer. And this, of course, includes multimodal therapies where we work closely with our radiation oncology experts, such as Dr. Addeo, who will be speaking as well today, and other experts, including geneticists, medical oncologists, and the patient's general OBGYNs and primary care physicians for survivorship care plans. So thank you so much for the chance to speak to you today.
Great. Thank you so much, Gloria. If there's any questions, if you guys would like to just put them in the chat, feel free. We can, again, this is very informal, and we can answer questions as we continue. I'm going to take then a few minutes to continue the conversation that Dr. Huang just started and talk a little bit more about breast cancer and ovarian cancer. and how they relate to each other. I'll talk a little bit about really my passion, which is early detection of these cancers. So hold on one second. Let me just share my. Um, Dr. Huang spoke so great about gynecologic cancers and how the paradigm of these cancers is changing. So I'd like to take the next minutes to discuss a little bit more about detection of these cancers, how much time and effort is being spent right now in improving early detection, in improving prevention of these cancers, as well as the fact that the treatment of cancers nowadays really has become truly a personalized approach. We don't treat cancers the same way just because cancers are the same. We truly treat the patient, we truly treat the woman. We study all the cancers, we study all the tumors, and knowing what mutations the particular tumor has, we are able to offer targeted, specific therapy to her. And that's certainly something different. That's not anything that we used to do before. And we are super, super excited about the future and about the present. But I'd like to talk a little bit about what comes before. I'd like to talk about not just about early detection of cancer, but about the Holy Grail. The Holy Grail is cancer prevention. So much of what we are trying to do now is identify the women who are at higher risk for different cancers. And a great amount of that information comes from family history and from the genetics. And this is just one of the examples of one of my patients who, when we started discussing her family history, clearly had genetic predisposition, and through which her genetic mutation was found, and hence cancer in her was prevented. And the driving hypothesis of so much of this work is that many patients might be at risk for several cancers based on personal or family history, genetic status, or personal history of a TPR hyperplasia. And it's so important to know because that's the first step. First step is the knowledge of knowing who is at higher risk and knowing what they are at high risk for. Because if we know that, then different modifications can be done. And we will talk as to what those modifications are. And they're always the same. They're always either surveillance or chemo prevention or surgical intervention. So for any cancer, when we worry that the patient could be at risk, we talk about what can be done to decrease that risk or hopefully eliminate it completely. Traditionally, management of this patient has not been easy. There's a lot of frustration in the medical community, but even more so among women and among men and patients and families, that frequently these genetic mutations were taken care of by a very specific provider, very specific, one doctor who really did not talk to other doctors, and there was a lot of disconnect about these mutations. And frequently, women did not get the care that they needed because, if somebody had a specific mutation they had to do with a breast, they would just be managed by the breast physician without really understanding the correlation between breast and ovary, and making sure that the whole team of providers is involved in the optimal care. And that is what we're trying to correct. And that is what we're trying to improve. So we know now that approximately 10% of cancers are something called hereditary, which means that there's a mutation in the gene. However, we know so much more now, and we now believe that a much bigger number, closer to 30, if not 50%, actually carry some sort of genetic predisposition. And there's some sort of a gene that could be responsible for different cancers, as well as for other cancers in the family. So what are the risk factors? So frequently in the office, I talk to my women and my patients, and we always talk about, could the cancers that they have be due to a mutation? And how do we know if those are likely to be due to a mutation? And it's super important to know, because we want to make sure that if that's the case, we identify them so that further cancers can be prevented in her and in her family. So the risk factors for having some sort of a genetic hereditary cancer is early age of onset, so when cancers happen younger in life, multiple affected family members, and you saw the pedigree I showed you in the beginning, and that's something we always talk about, related cancers in the family. And it's very, very important to remember that the related cancers in the family is not just what we think. You know, for somebody who has breast cancer, we're not just talking about breast cancer. We are talking about breast cancer having a very close relationship to ovarian cancer. And now we also think there's certain subtypes of uterine cancer that are also part of that family of cancers. This includes pancreatic cancer. This includes prostate cancer in men. You know, this is very important that when we talk about these female genes, you know, the BRCA genes, that this is not only women that this affects. There are certainly males that this affects as well. This includes melanomas of the skin. Multiple primaries, so a patient, a woman or man who has more than one cancer. Male breast cancer is something that we're always very careful with. Male breast cancer is very frequently associated with genetic mutation. In the older days, like 5 years back, we used to talk a lot about Jewish ancestry. The Ashkenazi Jewish women, as I'm sure a lot of us know, carry a higher prevalence of these genetic mutations. However, recently we have found out that Jewish Ashkenazi women are not the only ones who have this high prevalence, that there's a certain population of women from Italy, there's a certain population of Mexican women that carry similarly high prevalence of these genes. So, you know, whereas years back, we used to ask the woman, you know, are you Jewish Ashkenazi descent? And if she said no, we wouldn't worry as much. That's no longer the case. We know, again, much more about different mutations, different ethnicities, and also we are much smarter now. We know many more genes now than we used to do years back. And then pathology as to exactly what kind of cells there are. And the genes that we worry about, you know, are multiple. So BRCA1 and BRCA2, I'm sure many of you have heard of. So BRCA1 stands for breast cancer 1. Cloned in 94 and increases risk of breast cancer, ovarian cancer, and prostate cancer in males. BRCA2 for breast cancer 2, cloned soon after that in 95, and carries lower risk but of more cancers. Breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, and this is the cancer that's more associated with male breast cancer. This is the life cancer risks. So in the population, so if you don't have any genetic mutations, women have approximately 11 to 13% chance of getting breast cancer during their lifetime. But if a woman has a BRCA1 or BRCA2 mutation, then that risk is significantly higher. Similarly, for the ovarian cancer, the risk is approximately 1.4%. But could be as high as 60% for BRCA1 and as high as 40% for BRCA2. And that risk similarly is increased for second breast cancer primary. Again, up to 65% in BRCA1 patients. So prostate cancer, again, is quite common in males. 16% of general population has a risk to develop prostate cancer. And that risk is as high as 30%, so doubled in BRCA1 and BRCA2 males, as well as male breast cancer, which is super uncommon in general population, could be as high as 10% with BRCA2. And you can see similar increase with BRCA2 in pancreatic cancer. So what can we do? And this is, we mentioned this in the beginning of the talk. So when we believe that a patient, a woman or male, is at a higher risk for a specific cancer, what can be done? You know, I very frequently have this conversation in my office with women when they are reluctant to get genetic testing done because very frequently there's fear as to what would I do with this information. If I know I have a genetic mutation, what does that do? Does it add anything? Does it help me at all? And it certainly does. I never advocate for checking genes for which we have no solution. But for a great number of these variants in genetic deleterious mutation, there's unquestionably prevention that can be done. Knowledge is power. So the way that we usually look at this kind of management is always similar, no matter what kind of cancer we are talking about. So the biggest one and probably the easiest one is the lifestyle modifications. Not the easiest one, as we'll talk in a little bit, but the cheapest usually. Chemo prevention, surveillance, and then the most aggressive one, which is surgery, which is only reserved for truly, truly high-risk population. So for the breast cancer, for those women who are at significantly higher risk, the most definitive, but the most aggressive, of course, is mastectomy. And this one is reserved for women at highest risk. And it's a very complex procedure, reduces the risk substantially, but the psychosocial implications are not well studied. We know that even for women with BRCA mutations, when they undergo mastectomy, 0% of women actually ended up having breast cancer compared to 7% of those who did not. Surveillance, which just means closer watching, consists of clinical breast exams. And right now there's a lot of debate in the literature where breast exams should be done by providers or not. For this population, we continue to encourage it. Self-breast exams, again, very important, especially for women to know what their breasts feel like, so that if anything feels abnormal, they will be aware of it. Breast MRIs, as well as mammograms, and that starts at age 25 for women who are truly at high risk because of genetic mutations. MRIs are very debatable. For those of you who get them, it's always a battle with insurance companies to try to approve it. This is not meant to replace the mammogram. Mammogram looks at things differently, and there's a lot of benefit to the mammogram as well. It's not proven to impact survival, and that's why it's so hard to approve by insurance companies, but nevertheless, it adds to the full picture, and we recommend getting it for these women. Chemo prevention is a little bit more complex. Again, this is for women at higher risk, and the medicines that are recommended as these risk reduction agents are tamoxifen, aromasin, and Envista. And there's no free lunch, so there's some side effects to them. So this similarly is reserved for women at significant risk. For women who are at significant risk, who take these medicines, they decrease their risk by a good 50%. So the benefit is substantial. I'll skip a little bit. This is just how these medicines work. And again, some of them, all of them decrease the risk of breast cancer, but some of them are good for the bones, some of them are not good for the bones, some of them are good for the uterus, others are not. And this is to show that in all these women, in women who have mutations and who have higher risk, tamoxifen significantly decreased the risk of breast cancer. As I mentioned, no free lunch. Side effects of tamoxifen are hot flashes, some leg cramps. There's a very small risk of blood clots, very small risk of endometrial cancer, and cataracts. The easiest, as I mentioned, well, not the easiest, but the most straightforward one, of course, is lifestyle modifications, and we do a lot of those conversations. The biggest one is alcohol. I'm sure you guys have seen the literature that there's definitely correlation of high alcohol use, higher alcohol use to increase risk of breast cancer. Women who drink 1 to 2 drinks a day is associated with 30 to 50% increase in breast cancer. So usually the recommendation is to have less than 1 drink a day. So it's manageable. So less than 7 drinks a week. And it actually doesn't matter if you do all 7 at once. So if you do once every day, the total should be less than that. And then weight. There's a very specific correlation of weight to risk of breast cancer. So especially after menopause, women with a BMI of more than 33 had 27% increased risk versus women with BMI of 21 or less. And we know from the Nurses' Health Study, a study from which we learned a lot about these cancers, that 10 kilogram weight gain since menopause had almost 20% higher risk of breast cancer compared to weight maintenance. So as lifestyle modifications go, alcohol and then achieving and maintaining a healthy weight are the 2 most important aspects. I won't spend too long, but there's of course pluses and minuses of hormone replacement therapy. As you know, hormone replacement therapy used to be something that women used to get routinely until the study was published, the Women's Health Initiative, the nurses study, that showed that there was a substantial 26% increase in breast cancer, and that's when all the hormones stopped. Even though we don't think that's really the case, some subsequent studies that were done showed that when used with estrogen alone, there really was no increase in breast cancer. So nowadays, we truly believe that this is a shared, kind of very personalized decision between a woman and the provider, understanding risks and benefits. And after the women with a BRCA mutation undergo definitive surgery, so if the women, and we'll talk about that in a bit, if the women, if their ovaries and tubes are removed at a younger age, there's a lot of literature that supports the use of hormone replacement therapy in these women. It is completely safe, and it still decreases the risk of breast cancer by as high as 50%. And that's all been very well studied. I'm going to jump briefly for the next few minutes to now the risk management of ovarian cancer. Dr. Huang mentioned this already, but we do very similar approach: surveillance, chemo prevention, or prophylactic surgery, which again is the most aggressive. Ovarian cancer remains unfortunately deadly. 22,000 cases a year, 15,000 deaths, unfortunately, in comparison to the breast cancer, which is the most common, but much more curable. And the trouble with that is that, as again, many of you know, that ovarian cancer, unfortunately, is the cancer that whispers. Even though we actually don't think it's the case anymore. We now do not think that ovarian cancer is whispering. We really just think that nobody's listening. Over the past couple of years, there's been a lot of studies that showed that even though a great majority of women with advanced cancer, stage 3 and stage 4, had symptoms, women with stage 1 and 2, great majority of them also had symptoms. It's just that the symptoms were so vague that they were perceived by the woman and also by her providers to be normal, to be menopausal, to be hormonal, to be just a normal thing that women undergo, which is of course not the case. So much of what we do with these symptoms is educating women and advocating and teaching them to listen to your body, that, as Dr. Huang said, that if you have these symptoms, the bowel symptoms, the bladder symptoms, then just not feeling great and having some bloating and distension, and your clothes are not fitting well. And of course, we all have those symptoms. All of us feel that. The difference between what we all feel and the symptoms that are actually abnormal is that women who ended up having cancer had these symptoms every single day for 2 weeks. So we do a lot of advocacy work and a lot of empowering of women to listen to your bodies. And when you feel that something is wrong, you present to the provider and you demand the care that you deserve. You don't take no for an answer. You don't let the provider tell you that, these symptoms are normal and just it's menopause, that if you continue having these symptoms, that you need to be evaluated. This is, like I mentioned, those are the symptoms that women feel, and that it's so important to be aware of it. The trouble with ovarian cancer and the symptoms is that there's a lot that it mimics a lot of other things. You know, it mimics endometriosis, the most common mimic. It mimics irritable bowel syndrome, inflammatory disease, and interstitial cystitis. And that's why at times it's a little bit difficult to distinguish. But the most important thing, again, is just to know that this is something that's not same for you as usual. So when women have these symptoms, it's very important to be seen. And many women with these kind of symptoms actually are not seen by gynecologists. They're seen by a GI person or GU person. You know, actually the most common doctors who see women at this stage are gastroenterologists, urologists, chiropractors, and psychologists. That was number 4. And then these women always, it's very important for them to have a sonogram and some blood work and sometimes a CAT scan and then a referral to a gynecologist, which is very important. Sorry about that, you guys, the beauty of Zoom. So we don't do screening for ovarian cancer. It doesn't really work. CA125 is a tumor marker. That's just not a great tumor marker for this. CA125 is a very good tumor marker and something that we use very carefully, very closely for surveillance of cancer. But we do not, it does not work great by itself. So we use it together with an ultrasound beforehand. And this is just studies that show that together with an ultrasound for women at high risk, using imaging, which is ultrasound together with a blood test, is the best modality, best way to try to find these cancers early. And then, of course, the most aggressive one, which is surgery, and surgery for prophylaxis for ovarian cancer is really only reserved for women at highest risk. So who are the women what are the factors that are associated with high risk of ovarian cancer? And those are women who had early menarche, late menopause, never had children, infertility, endometriosis, and then the most serious ones, which are the genetic factors, BRCA1, BRCA2, and Lynch. There's also environmental factors. You guys all know, I'm sure, about talc use. There's a lot of debate on that. But there's cigarette smoking as well as asbestos that's considered risk as well. And the thinking for that, we don't have time to talk about this now, but there's 2 different thoughts of ovarian cancer. One thought, as Dr. Huang mentioned, that some of these cancers actually arise in the fallopian tubes, and ovarian cancers are actually not ovarian cancers at all. They're fallopian tube cancers that have spread to the ovaries. And the other thinking is that every time a woman ovulates, that there's some sort of a tumorigenesis that happens. So the less time she ovulates, the less is her risk. The more times, the more is her risk. That's why having a lot of children, having 5 children, that reduces your risk of ovarian cancer by 50%. I got very close. I got to 4, very close to that reduction. Breastfeeding every child for 1 year also gives you 50%. The other way to decrease your risk, which is much more sane than having so many children, is birth control pills. So any woman who uses birth control pills for 5 years during her lifetime decreases her risk by 50%. Anybody who uses birth control pills for 10 years decreases her risk by 80%. And 15 years decrease her risk by 90%. So huge differences. And this is something that I always talk about. Doesn't matter what talk I ever give, I always talk about that. You know, taking birth control pills is really the biggest thing that we as women can do for risk reduction of these cancers. And then tubal ligation, Dr. Huang mentioned, because we think that some of these cancers actually originate in the fallopian tube. So removing the fallopian tube is actually a huge thing that we can do. It decreases your risk by 70% when you do it. So I'm going to bring us to the end just so that we have time for questions. And, you know, I just wanted to make a few points about the gynecologic cancer before Dr. Addeo will take it over with talking about radiation oncology. So much has changed in the field of gynecologic oncology. So much research is being done. A lot of you on this call are actually touched firsthand by this and know the advances that we have made. We no longer treat everybody the same. You no longer just come and get the same chemotherapy no matter what. Things are now truly different, truly personalized and individualized, and we understand what mutations the cancer has. We studied this in mice, and we really understand what treatment is best for you. This is what allows women the best outcome, the longest survival, cure, but also quality of life, allowing to live your life how you are and not allowing cancer to really change your quality of life. But so much more should be done, and so much more has to be done, and so much of that should be done in early detection and prevention. But the biggest part of it, really, more than anything else that we've done in the lab, more than testing, more than different tumor markers or biomarkers that we're looking at in the blood, is really kind of awareness and advocacy and knowing your own body and talking to your friends. And we as women and men on this call, you guys are the biggest advocates. When somebody, I cannot tell you how many women I have talked to subsequently or diagnosed after one of these conversations, because when we stop to think and remember that these things kind of stick with us and kind of influence what we remember going forward. So thank you so much for the time, and we're so thrilled that you're with us today. I'll let Dr. Addeo do her part, and then we will have time for questions.
Thank you. Let me see. So I put together a few slides about radiotherapy applications for gynecological cancers. And for the people in audience who are not quite familiar with radiation therapy, what is radiation? It's a treatment modality that uses high energy particles and high energy electromagnetic waves to destroy cancer cells. And the target for radiation treatment for radiation waves is basically the DNA molecule of the cell. The radiation damages the DNA, breaks the DNA, and produces, in the end, cancer cell death. So basically, radiation therapy clinically has been a therapeutic component for gynecologic malignancies for many, many years. According to evidence-based treatment guidelines, has been published an article. They looked into estimated frequency of use of radiation for gynecologic malignancies, and can see that most commonly we apply radiation for cervical cancers, up to 60% of patients, then endometrial cancer 45%, vulvar cancer 40%. Actually, vaginal cancer is very rare, but it's almost 100% of the cases require radiation, and 10% of patients with ovarian cancer, so the least. So there are two approaches when we administer radiation for gynecological cancers. One is external radiation, and the second is internal radiation or brachytherapy. So this slide illustrates the external radiation is administered with this big machine called linear accelerator. The patient is positioned on the treatment table, and radiation treatment is produced here in the head of the machine and is aimed to the area that we want to treat. For gynecological cancers, we use a lot brachytherapy or internal radiation. What does it mean? That applicators are placed inside the body of the patient, and then they are connected to the machine that is housing the radiation source. Most frequently is iridium-192, is high dose rate brachytherapy device. So when we turn on this machine, the source of radiation travels through this connection to the patient's body, to the applicator, delivers the radiation, and after the dose is delivered, it returns back to the housing machine. Those are some examples of applicators that we use for brachytherapy for inside radiation. So they are actually placed in close proximity to the tumor or targeted area, and sometimes right in the tumor itself. So for example, those are vaginal cylinders. Those are thin hollow tubes that are actually introduced in the uterine cavity and placed in proximity to the cervix for basically for cervical cancer. And those are needles that actually are used for brachytherapy when we want to treat gross tumor. So they are placed inside the tumor itself. So there are basically three main clinical indications for radiation in practice. One is related to the surgery that removes the cancer. So we know surgery, we want the cancer to be removed by surgery, but sometimes radiation helps before surgery to shrink the tumor and make the surgery maybe a little bit less extensive. And sometimes we give radiation based on the stage and risk factors after the surgery. In this situation is given to prevent tumor or to decrease the risk of tumor recurrence. So radiation, when radiation is given related to surgery, can be administered either external or internal, and usually the duration is 3 to 5 weeks course. Another application is definitive treatment, when tumors cannot be removed by surgery. So we rely on radiation to control those tumors. Usually chemotherapy is given together, most frequently in the cervical, vulvar, and vaginal cancer. And again, when we treat definitively, sometimes it's a combination of external and internal radiation, and sometimes it's only external radiation, but the course is long because we need to give a higher dose, so 6, 7, even more weeks of treatment. And of course, for palliation, when gynecological tumors themselves or metastasis cause symptoms, then we give short course of radiation, external radiation treatment, 1 to 2 weeks. And example of symptoms are like bleeding, pain, pressure, obstruction. That radiation has been proven quite successful in palliating. So it always has been a concern for treatment-related side effects, radiation-related side effects. So basically, technical advancements that have been achieved in the last years allow us to get a better cancer control and decrease side effects. And for gynecological cancers, we are looking at side effects related to rectum, urinary bladder, bowel, because those are organs close in the area where we administer radiation for these diagnoses. So, for example, technical advancements are software algorithms that have been created and allow us to incorporate the PET-CT scan images, MRI images in our treatment planning. Another advance that now it's advancement that is now part of our daily treatments and standard is intensity modulated radiation therapy. This is a way to administer radiation in a very conform way, conform to the shape of the tumor. So in this way, we could increase the dose that we administer to the tumor, sparing healthy tissues around it. Another good advancement that we also apply on a daily basis is incorporation of high quality images taken just before each treatment session to make sure that patient is positioned correctly and radiation is administered with high accuracy. So this is image guided radiation therapy. And our linear accelerators, so our machine, the external radiation machines, are very capable, and we can obtain these images before each treatment. There is promising research that probably will increase the good results. And for example, new combinations of radiation therapy with systemic treatments like immunotherapy or inhibitors of DNA repair mechanisms in cancer cells, like PARP inhibitors. And even for the radiation, modalities, there is new radiation treatment devices that are being tested. For example, this is a miniature X-ray source XOFT system that gives a precise concentrated dose directly to the tumor site. So this can be applied to breast cancer, but also to gynecological cancers. So it's always new research and new results that we are looking for. Thank you. That's it.
Wonderful. Thank you so much. So we would love to open it to questions. If you guys have any, you can do it probably live if you want to raise hands on Q&A. We're happy to talk about anything you guys would like to talk about. We're here at your disposal. And if not, then we finish 3 minutes earlier. All right. Well, thank you so much, everybody. We love being with you.
Oh,
hold on.
I think there are a couple of questions on the chat, actually.
Yeah, here we go.
One is for you, I think.
So the first question, Dr. Ratner, can you just repeat whether using birth control pills reduces the chance of ovarian and breast cancer? And it's cut off. Let's see if there's a way I can get. So, Cynthia, I'll talk a little bit. It cut off a little bit at the end if you would like to just, if you'd like to type more. So, birth control pills unquestionably reduce the risk of ovarian cancer. And as I mentioned in the numbers, very much so, very significantly so. If you had breast cancer, it's really the only time where you got to talk to your provider to talk about pluses, minuses, because a lot of breast cancers are hormone sensitive. And we would not want to do that if you had breast cancer, because even though it would decrease your risk of ovarian cancer, it would potentially increase your risk of breast cancer. So if you never had breast cancer, then we very much feel that the benefits that you get from the reduction in ovarian cancer and uterine cancer outweigh all the risks, and very much feel that it's worthwhile. But if you had breast cancer, that would be the only time where you would be careful, and you would need to speak with your doctor to make sure that the breast cancer wasn't hormone sensitive. The second question is, what are the latest findings for treatment of ovarian cancer with immunotherapy? Which one specifically? So I can start, and Gloria, I'm sure you will like to get. So immunotherapy is this wonderful new treatment, new modality that we have started using. Unfortunately, it does not seem to be for everybody, and that's especially the case in ovarian cancer. In ovarian cancer by itself, only 7% of women respond to immunotherapy, so not a great number. But it is just like everything that we talked in the talk today, it is truly personalized and individualized. So when the cancer cells are studied specifically for the patient, some of these cancer cells have specific mutations. And for some of these specific mutations, immunotherapy is very effective. So Keytruda is the one that we would use, but again, it's not for everybody. It's specifically for those women with mutations. And then there's a question about PARP inhibitors, and that's very similar. That for PARP inhibitors, there's nowadays a lot of literature on PARP inhibitors. In 2014 was the first time where PARP inhibitors became part of the treatment regimen for ovarian cancer. At that time, it was only for women with ovarian cancer. with BRCA mutations. Subsequently, we have found that PARP inhibitors are helpful for women, not just with BRCA mutations, but with other mutations as well, something called homologous recombination deficiency. And we now use PARP inhibitors in treatment and also in maintenance, which means that some women take PARP inhibitors when they are cancer-free to prevent or delay cancer cells from coming back. But similarly to what I mentioned about immunotherapy, similarly, it's not for everybody. It truly needs to be smart and directed, and cells should be studied, these specific mutations assessed, and decision made who really would benefit from these versus others. Gloria, if you would like to add, I think then Cynthia is able to speak.
Sure, yes. I agree in terms of immunotherapy that what we have available right now and the data that we have is that immunotherapy has a highest likelihood of success if the tumor has certain characteristics such as mismatch repair deficiency, you might hear that term, or microsatellite instability. So those type of changes happen a bit more frequently in cancers such as endometrial cancers and colorectal cancers compared to ovarian cancer. But some ovarian cancers can have that feature. For ovarian cancers that don't have that feature, what we're looking to is probably going to be combination therapies where immunotherapy is combined with other agents, those that target the abnormal blood vessels of tumors, those that target DNA damage repair. Sometimes our drugs that target DNA damage repair, like PARP inhibitors, can actually lead to DNA changes that makes the body's immune cells more able to potentially identify those cells as cells that need to be eliminated by the immune cells. So I do think there's promise. Other areas, of course, that are of interest are even, speaking of HPV vaccines, other cancer vaccines. So potentially, I think right now everyone is more educated than we could ever imagine about mRNA vaccines, which are being deployed to combat COVID. So it's a new technology of vaccination, which definitely has promise for cancer, personalized cancer vaccines as well. So, basically stimulating your natural immune response to recognize abnormal proteins expressed by cancer cells. So other areas of immunotherapy too include things like CAR T cells. So basically expanding a person's own T cells that can recognize tumor antigens or tumor neoantigens. So I do believe there's a lot on the horizon, and these advances are being made possible by our much increased understanding of how these cancers develop, as well as new technologies that make it more efficient to consider these modalities. So yes, I'll pause there for a sec, and I see there's a few other questions, and then I think Cynthia had a question as well.
Yeah, Cynthia, do you want to go ahead with your question?
Can you hear me?
We can.
Oh, wonderful. Thank you so much, doctors. This has been so very informative. I was asking the question about using birth control pills, and not for myself. I'm 67, that ship has sailed. But as I say, I had breast cancer in both breasts at age 52, and I'm concerned about my 32-year-old daughter and my 35-year-old daughter-in-law, who's also, her mother had breast cancer. So when I heard about the birth control pills helping the health of those two women, that's where my ears turned on. So is that the kind of information they should be talking to their gynecologists about?
Yeah. Cynthia, that alone is worthwhile this 1 hour. If this is what you heard, then you're going to tell your daughter, it's wonderful.
Absolutely.
We're so thrilled.
Thank you so much.
Of course. So Cynthia, so I think important thing, not of course to go into your history, but very important thing is really just to like know your risk, like understand your risk. So for a family history like yours or history like yours, it'd be very important to understand, again, like genetic mutations. Is there anything that predisposes you or your daughter to increased risk? Um, and even if there was, like a lot of my women, a lot of my young patients whose moms I take care of always ask me, well, my mom had ovarian cancer, or my mom had breast cancer, or, I have a BRCA gene mutation. Does that mean that I shouldn't be taking birth control pills? But it's the opposite. It's on the contrary. If the only time not to take it is if the woman herself has breast cancer, but the mom having breast cancer or even having BRCA mutation herself is the reason to take it, not to take it. Because even for those women who have BRCA mutation and they have a significantly higher risk of ovarian cancer, their risk also would decrease by 50%. So if somebody had a risk of 20% and they take birth control pills for 5 years, the risk will go down to 10%. It's respective decrease. So thank you for your question. But yes, the important thing is to know genetics to make sure that they're not at risk for something else. But that is not a contraindication. On contrary, that's an even stronger indication.
Thank you.
Gloria, can you see the question over there?
Yes, I see a question regarding HPV vaccination. And yes, one of the advances has been the expanded eligibility for getting HPV vaccine. So currently, HPV vaccine Gardasil 9 is FDA indicated from ages 9 through 45 for boys, girls, men, and women. And so most efficacious, considered on time for children to be vaccinated by age 11 to 12, and there will be a very robust immune response. And as a preventive vaccine, it prevents infection, but has minimal effect on established infections. So that's why there's lesser benefit as one gets older, and there's a higher likelihood of having been exposed to common HPV types. Given that there's 9 different types in the current vaccine, there is still probably some benefit in many adults who've not had a chance to be vaccinated. So it's an individualized thing. I would suggest speaking with one's physician about the pros and cons, but definitely is a consideration for both men and women, since many people of the older age may want to have catch-up vaccination because there was less availability or no availability during their childhood and childhood vaccine schedule. So that's a great question. And I think another question which Renee has addressed is eligibility for clinical trials. So Renee Gaudet placed some good websites to look for trials. Clinicaltrials.gov, for example, you can search by geographic location, cancer type, what phase of clinical trial. And then in terms of local clinical trials, Renee put the website up for the Yale Cancer Center website as well. Let's see.
I think there was a question from Audrey about genetic mutations in 2017. So, Audrey, it's a good question. We always, I'm a huge proponent of saying, yes, retest. If it was longer than 2017, I would definitely retest. 2017 was already the time where we did this extended panels. So you're probably okay from 2017, but anytime you're even thinking about it, I always just urge, reach out to the genetics counselor where you got it done. And then just ask them, they routinely get these phone calls and they can just glance at yours and make sure that everything was done and there's nothing additional. If you had it done before 2014, I always say to redo, because we have so much more now than we did before. But 2017, most likely you're up to date. Well, thank you so much, everybody. We had such a wonderful time with you today, and we hope to do this again. And please reach out to all of us at your disposal in the community. So we're always available to you. Thank you.
Thank you for having me.
Renee, and thank you so much for organizing. Thank you, Daniela and Gloria. That was excellent.
Nice meeting you guys. Thanks.
Nice to meet you too. Thank you so much, ladies.
Bye. Have a great evening. All right. Take care, everyone. Thank you for joining us.